could you go over knee valgus during a squat ascent in the context of the model? For those of you who don't know what knee valgus is basically where the femurs kind of knock into internal rotation as you come out of the bottom. It's a very common thing that happens. And so we have to look at, why would that be useful? Why would the knees coming together like the Beatles song, but maybe not in a cool way always, be an advantageous thing to happen when it comes to the squat? Well, I'm glad you asked. Let's dive into that. So when I'm coming out of the bottom of the squat, I have to put force into the ground. The force is strong with you. So I have to be able to put force into the ground in order to come out of the bottom of the squat. And when I'm producing force into the ground, that's associated with more internal rotation of the femurs, or just internal rotation in general. And so what will happen, if I look at this from a pelvis perspective, is internal rotation is going to be associated with the sacrum nutating or tipping forwards. That needs to happen. If that doesn't happen, well then guess what, folks? You're going to have to find another way to do it. So when I push out the bottom of the squat, the sacrum nutates. That allows the guts and the viscera within the ventral cavity to actually be pushed upward, which that has to happen when you ascend out of the squat. When I'm dropping down into the squat, the viscera pushes down, and that's why the pelvis ideally creates more of a vertical displacement, because the sacrum attains a counter-nutated position. When the sacrum attains a counter-nutated position, it allows the viscera to drop downward. It catches the viscera effectively, and life is good. When I come out of the bottom, I have to essentially push the guts upward because the guts are moving down. Well, I want to move up, so therefore I got to push the guts up. That's where sacral nutation is useful, because that is associated with the exhaled position. So when you exhale, the position of the pelvis changes, because that is associated with altered contractile capabilities of the pelvic floor. That allows the viscera to ascend up, and then you can come out the bottom. But folks, what if under a given squat I can't do that for whatever reason? Maybe the load's too heavy, because we oftentimes see knee valgus with a lot of our Olympic lifters. We'll see it when we're moving maximal weights. So then why would performing femoral internal rotation associated with knee valgus actually be useful in this particular strategy? If your body can't attain that nutated position, what will happen is you still have to be able to internally rotate. So you have to find a workaround in order to make that movement happen. The workaround in this case will be to anteriorly orient or tilt the pelvis. When you anteriorly orient or tilt the pelvis, that's going to allow the femurs to be more in a position of internal rotation. So I want you to perform a quick little experiment on this to see it for yourselves. So if you watch me from the side, I'm going to internally rotate my arms. You ready? So you see I have X amount of range of motion. Now, watch this. I can quickly pick up a boatload of internal rotation without doing a single stretch or anything. You ready? Boom. Wow, look at that. I got so much IR now. False. What happened, all I did was I changed the orientation of my thorax. If I grab Ted, our boy Ted, good old Ted. If I just do this by anteriorly orienting or tilting the thorax, that changes the position that the glenoid, that part in the scapula, or on the scapula where your humerus connects with, it changes the orientation of the glenoid, so it gives the appearance that there's more internal rotation available. And in fact, it does allow me to internally rotate, but it comes at a cost. When I perform internal rotation in that fashion, I'm not getting internal rotation at the glenohumeral joint, so I don't have the full movement excursion at the glenohumeral joint. All I did was change the orientation of the thorax to allow that to pick up. So what's happened is now my humerus, my scapula, my thorax all move as one unit in order to complete the task, which under certain circumstances that could be useful. That might allow you to do certain things with your body that you might not have been able to otherwise. But it comes at a cost. When you don't have relative motion available between the bones, there's increased loading through certain joints, because now you can't distribute the forces as effectively because there's fewer places to do so because you have less overall available motion. That's one thing. The other thing is that when that happens, that could potentially increase stress on certain areas and cause issues. So that could be undesirable. Now let's apply that same concept in the context of knee valgus during the squat. If I grab my grandson here, I need to be able to internally rotate, which is nutation of the sacrum. I can't do that. So if I anteriorly tilt the pelvis like so, that changes the orientation of the acetabulum to where I have the appearance of more internal rotation. Is it real internal rotation? Not necessarily at the femoroacetabular joint. You've just changed the position of the pelvis to allow you to pick up more internal rotation. But it's done so at the cost of preserving relative motion between the femur, the pelvis, back, etc. When that happens, then folks, you don't have the ability to distribute the forces across multiple joints. The bones lock into one place essentially, and they move as one unit. And so there's a trade-off when you do have knee valgus on that particular squat. And it's probably why we commonly see that during heavier loaded activities. Because the more you push it to the limit, the less likely you are to preserve range of motion between all the joints, because your body has to create a ton of tension in order to move something heavy or move quickly. So that's not uncommon. But that's why it happens, is because your body's current strategy isn't enough, so it changes the orientation to allow you to complete the task at hand. And that's likely why we see knee valgus with a lot of our squats, especially when it's heavier and ascending out of the bottom. Knee valgus happens with an anterior orientation of the pelvis. Not a good time in certain scenarios, but basically what's happened is you're able to produce force, but you've done so at the cost of losing relative motion between the bones. Now, our question is this problematic? That's the next question. And so what we have to look at is, well, is there any research showing that knee valgus during a bilateral squat is bad? Well, the times that we see valgus being bad in the research is when you're doing single leg squat testing. And the reason why that is because that's associated with, or they use single leg squats to assess injury risk. And the second thing is when you are performing a single leg squat, if you get a lot of valgus in that position, it's also a position that is often associated with injuries in sports. So a lot of your ACL tears and things of that nature are usually because there's a substantial amount of dynamic valgus, and that could be associated with injuring specific areas, which is not cool. So now we have to ask, though, folks, is there an injury risk association with knee valgus during bilateral squats? And with a brief literature review, I didn't find anything either way. It doesn't appear as though there's evidence for or against bilateral squats and knee valgus. So that doesn't mean that it's a good thing, but that also doesn't mean that it's necessarily a bad thing. We just don't know. But what I would say in that case is, with absence of evidence either way, we have to look at what is biomechanically desirable when we're performing something like a squat. And in my mind, there's four things that we have to consider when looking at, is this amount of valgus useful? Because we know based on what we've just discussed about the biomechanics, knee valgus is going to happen when there's a loss of relative motion that allows me to put enough force into the ground to be able to come out the bottom of the squat. So if that's the case, then we got to look at, okay, when is it acceptable, when is it not? And there's 4 things I want you to consider. The first thing is, what is the intensity of the lift? If you look at most elite Olympic lifters when they're performing a snatch or a clean and jerk, you're probably going to see some knee valgus. And so it may be that there is an acceptable amount when you're pushing it really hard. So if you're doing your 1 rep max or it's game time and you got to do that in order to put up the weight, then it's probably okay, considering these other variables as well. But now let's say you squat, and as soon as you bend your knees knock together, and it's body weight. Well, that's probably not desirable because you're using a strategy where there's less range of motion available when the task isn't necessarily uber challenging. So if you're seeing knee valgus in that context, that's probably not desirable. Or even just coming out of the bottom of a bodyweight squat. That strategy should ideally only be reserved for higher level things. And so if you're using it on a lower intensity strategy, you probably have to work on things to minimize valgus under that particular situation. That's one thing. What is the intensity of the lift or the movement? Second thing, can a person hit desirable depth? This goes back to the person who gets valgus as soon as they dip down into the bottom, or as soon as they start to dip down into a squat. If you get valgus immediately on your descent and your ascent when it's not much weight relative to your strength or whatnot, then there's probably something that we should work on. You should be able to get an adequate amount of depth, because if you can get full depth on a squat, you at least have more available movement to you in your repertoire that can even out the workload distribution across multiple joints. Life is good. The third thing is the body shape that we're going after desirable? So depending on what squat variation you are looking at, does it meet your standards that you would like to see with a squat? Now, there's going to be individual differences, of course. That goes without saying. But if you're choosing a squat variation where you expect verticality of the pelvis and they're shooting way back and they're not hitting depth, and then they have to use knee valgus in that position to come out the bottom, it's probably not a desirable movement strategy that we want in that particular situation. And then the fourth thing that we're going to look at is the client, your supreme clientele, feeling the sensory components that we oh so desire? Meaning, if you have someone and they're performing a squat and they're getting knee valgus and they're saying, "Hey, coach," or "Hey, therapist." Do people say that to therapists? But they're saying, "Hey, you, I'm feeling my tensor fasciae lata in my back during the squat variation." That's what you want, right? Well, if that's the case, then, we're using squats to work the quads, glutes, all that stuff. Probably not matching what we want from a movement perspective. So it would behoove us to change that and alter the mechanics in a manner so that's not the case. This is especially true if you got someone who's getting a fair amount of knee pain with squatting. Is that going to happen from time to time? Sure. Do we want knees to be hurting every single time that you're squatting? Probably not. So it's just something that we want to consider. To summarize this amazing question by my dude, Manuel. Big things. Valgus happens at the knees when the pelvis anteriorly orients as a unit. That might be needed in some instances to put enough force into the ground so you can ascend out the bottom. Is that bad? We don't know. There's just not enough research either way. How do you know it's appropriate? Depends on the intensity of the lift. Higher intensity, probably more is acceptable. Can a person hit enough depth? If you're doing knee valgus at the beginning, not good. Is the shape that you want during the particular exercise desirable? Yes or no, maybe so. If not, take note of that, change the mechanics needed. And does your client feel what they should be feeling? If they don't, then you probably got to reevaluate. There's probably something else going on. You might need to change the way that they're performing that task. And if you do those things, knee valgus is going to be either a thing of the past or it's not going to be the big deal that it sometimes can be. Awesome question, Manuel.